Okay, so we'll be beginning with arrhythmia. So, what is arrhythmia? So, I was telling you that arrhythmia is a rhythmia. It is like there has to be a proper rhythm, and once you are going out of the rhythm, then that is called as arrhythmia. So, when I say normal rhythm, so as far as normal rhythm is concerned, how do we, what are the definition, what are the components of a normal rhythm? When can I say that the rhythm is normal? So for that there has to be four component. Number one is that what is the rate, what is the frequency. Second component is that what is the velocity. Third component is what is the path, and fourth component is what is the rhythm. Okay, so like suppose we say that there is conduction from atria to ventricle going on, but that conduction is going very slow, or suppose the conduction is going very fast. Both are problematic. So the velocity has to be normal. Then how many times the frequency is happening? Normal frequency is between 60 to 100 beats per minute. So if it is less than 60, that is not normal. If it is more than 100, that is also not normal. Next comes up the rhythm. Rhythm means whether it is regular or whether it is irregular. And when I say sinus rhythm, I specifically mean that the rhythm has been generated by SA node. Okay, so if SA node is not generating it, then it is useless. So if SA node is generating the rhythm, then that is called as a sinus rhythm. And next thing is that the path should be normal. So what do you mean by the path? So see, this is that path on the left hand side picture. So if you look at the left hand side picture or this bottom picture, so you will see ki in our heart there are two kinds of tissues present. Muscle. So one is called as the contractile myocardium, and the other one is called as the specialized myocardium. Specialized myocardium is also known as the nodal tissue. Okay, so there are only these two kind of myocardium present. Now, contractile myocardium means basically the one which contracts. So it will include the atrial myocardium and the ventricular myocardium. Whereas if you talk about the nodal tissue, so nodal tissues, there are again multiple nodal tissue. Many a times I find people, if I ask people that in case of heart, for the conduction of impulses, we use nerve or muscle. So many a times they say that produced by muscle but conducted by nerve, which is rubbish. In heart, everything is done by muscle only. And as far as conduction is concerned, it is always done by the nodal, like specialized muscle, specialized myocardium. So specialized myocardium includes the connecting path as well as the nodes which actually generate the action potential. It includes both are specialized. They are not calculated under the contractile myocardium. In contractile myocardium actually can't do anything except for like contraction and relaxation. Their job is only systole and diastole. Okay, this is their primary job. Otherwise, they don't have the capability to do anything. Now, if you look at it, then the first type of nodal tissue that you can you can talk about, that is the SA node. And after SA node, you can talk about the AV node, and after AV node, we can always talk about the this bundle of His. After bundle of His, there is like AV bundle, then right bundle branch, then left bundle branch, and then the Purkinje fiber. So this is how that entire spreading is going on. So this is how the specialized myocardium is present. Now, if we talk about the arrhythmia, how we can classify the arrhythmia? What are the various kinds of rhythmic damage or rhythmic abnormality coming up? So one way we can have it coming from ventricle, and another one is like above ventricle. So there can be a supraventricular or there can be a ventricular. And another thing, like I said, that 60 to 100 is normal. So anything which is beyond 100, that is called as tachycardia or tachyarrhythmia. And if it is less than 60, then it is called as bradycardia or bradyarrhythmia. Okay. Till this much, everybody has understood?
Yes, sir.
All right. Is she there?
Sir, আমি
হ্যাঁ আচ্ছা এসছিস
হ্যাঁ স্যার আছি।
ওকে ফাইন তো alright so over here we see that if you look at the tachyarrhythmia then you will see that as long as it is till 100 that is normal, but if it is more than 100 and if it is till 160 so then it is there is nothing to worry. Why there is nothing to worry? Because in various cases you will see that there is like whenever you are doing exercise, okay, whenever you are say jogging, when you are running, at that time also 160 heartbeat is like very common, very normal 160 heartbeat. And but if it is beyond 160 and if it is still 250 then it is called as paroxysmal. So Abhirup, do you remember what is the meaning of the word paroxysm?
হ্যাঁ স্যার দাঁড়ান বলছি। প্যারক্সিজম ওটা তো স্যার ওই জায়গাটা ভুলে যাচ্ছি স্যার কার ইমা স্যার ঠিক মনে আসছে না, ভুলে গেলাম। প্যারক্সিজমাল এটা
Paroxysm মানে on and off, মানে like suddenly it will start, suddenly it will go away. Okay, so paroxysm, like if I say paroxysmal fever can also come up in paroxysm, or say a person is having fever is fine but shivering can come up in paroxysm. So if shivering is coming up in paroxysm, so that is paroxysmal. So here this tachycardia can come up in paroxysm, so we call it as paroxysmal tachycardia. But if it is beyond 250 then definitely you should consider it to be a case of flutter. And I think flutter is a terminology which all of you know, because in English it is English terminology. People say that national flag is fluttering, huh? So if national flag is fluttering, now you understand what is how the flag flutters. I guess everybody knows that how flag flutters. So the way a flag flutters, similar way this will also do some fluttering. Understood what is fluttering? Pat, 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 pat,
Yes,
pat, 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 pat. It will happen in this way. So that is what
Sir?
is huh.
বলছি যে বিয়ন্ড 160 হলে হচ্ছে paroxysmal
Paroxysmal, huh.
আর বিয়ন্ড 250 হলে কেস অফ ফ্লাটার।
Flutter.
ঠিক আছে।
And beyond 300 it is a case of fibrillation. Have you seen in movies and all that, you know, there are two paddles which come up, and what they will do is they have got a machine, and then they will shout clear, and then some people will say yes clear, and then they will put the paddles on the chest, and then it shows like as in movie they show that the patient is jerking, the body, you know, jerks like that. Then have you seen that there are two paddles which they put it on the chest, then they shout clear and dhad, there's a electric shock given to the chest area. Have you seen that in TV or in anywhere?
হ্যাঁ স্যার।
So
হ্যাঁ স্যার
that machine is called as a defibrillator machine. So basically its primary job is to bring about changes in fibrillation. But since it is a electrical jhatka, so we can use it in various cases, but primarily the name of the machine is defibrillator, and we are talking about that fibrillation only. Again, you can understand that all these diseases can occur in atria as well as ventricle. So fibrillation is occurring in atrial, so atrial fibrillation, AFib. If it is occurring in ventricle, so ventricular fibrillation or VFib. Okay, so this is
কত বললেন বিয়ন্ড
300. Beyond 300. Similarly, if you see that it is the heart rate is getting lower than 60, so it is a case of bradycardia. So if it is again 40 to 60, then it is still okay, because of various condition it can happen. So it is mild bradycardia. If it is less than 40, then we consider it to be moderate, but if it is, you understand, 0, so definitely death. At 0 to 20, so you understand, we call it severe. So first, like we will begin with the tachycardia. And in tachycardia, I was telling you that tachycardia can occur in two ways. One is it can occur in the ventricle, so it is a VTach or ventricular tachycardia, or it can occur ahead of, like above the ventricle, so we can call it as a supraventricular tachycardia, SVT. Now, as far as SVT is concerned, you will see that it can have a atrial tachycardia if the entire atrium is showing the contractility, higher contractility. It can be a sinus tachycardia. Maybe your SA node has gone crazy. Your SA node is beating faster. Well, I mean, SA node is generating the impulse in a higher frequency. So that can be a sinus tach or sinus tachycardia. Then there can be a ectopic tachycardia. Ectopic supraventricular tachycardia. What is ectopic thing? Ectopic means anything other than normal is called as ectopic. Okay, anything other than normal is ectopic in any part of the body. We use this word. It is a very common word in medical science. Say for example, normally pregnancy occurs in the endometrium. When implantation occurs in endometrium, but suppose implantation does not occur in endometrium, it occurs in some other part of the body. It is called as ectopic pregnancy. So ectopic is a very, very common word. ठीक है ना? So when I say ectopic heartbeat, so that means similar thing, that it is coming from some other part. So that means we can say that normally SA node is supposed to fire, say in atrium. Suppose I talk about atrium. Say SA node is supposed to fire, but you see suddenly some other myocardium, which was maybe normally a contractile myocardium, suddenly it starts firing for some reason. So that is a ectopic tachycardia. Understood?
Yes, sir.
Okay. So over here, similarly, we can have a atrial flutter, we can have a atrial fibrillation. Similarly, it can also happen because of the AV node, which is present at the junction of the atria and the ventricle, AV node. So we can call it as the junctional tachycardia. So definitely junctional tachycardia will also come under supraventricular, because it is junction is also above the ventricle. So that is, so junctional tachycardia and atrial tachycardia, both of these things, they are present under, they are grouped under the supraventricular tachycardia. And in ventricular tachycardia, there is present VFib, ventricular fibrillation, and another thing is torsidi pointis. Now torsidi pointis is something which is ECG based, and it is very important. There are questions which have been asked in for you in previous years. So, but this is completely ECG based. So that is why we had that discussion on ECG earlier, and hopefully you will be able to understand. We will discuss it later on about the torsidi pointis. First, we have got other things to discuss. Now, if you look over here, I have mentioned that there is another classification which is based on the QRS complex. So there is something called as a narrow QRS complex, there is something called as a wide QRS complex. So now if you have developed an idea about QRS, you remember we discussed about QRS in the previous lectures?
Yes, sir.
So can you tell me if QRS is narrow, so in general what do you understand? Why QRS is narrow? QRS is narrow means time duration taken for the ventricular contraction or ventricular stimulation is if QRS is narrow, then what does it mean? Try, Paul, try.
স্যার বলছিলাম ওই কিউআরএস ন্যারো মানে তো আপনার ওই মানে ইম্পালসটা কম হচ্ছে, মানে হিউজ বা হচ্ছে ওরম না আর কি, লাইক
See, QRS narrow means, okay, Let me put it in this way.
স্যার ওটা কি মানে মানে খুব তাড়াতাড়ি হচ্ছে বলে মানে
ওকে, আমি একবার এঁকে দিই, বোঝাচ্ছি। সো দিস ইজ দ্য হাইট অফ R, this is the height of Q, and this is the height of S. So if for everyone QRS narrow মানে only this is QRS narrow. Amplitude is same, wherever there was R, there is R. Wherever there was Q is still present over there. Wherever there was S is still present over there. But this one, the width has decreased. So, okay. So, tell me, what is your opinion, Devasmita, once again? Obhirup?
স্যার কিউআরএস ন্যারো হলে ওই যে মানে কি বলবো ভেন্ট্রিকুলার যে সিস্টোলটা ওর টাইমটা তো একটু বেশি হচ্ছে মানে কম হচ্ছে।
Okay. And Devasmita?
মানে
স্যার, মানে-
ওটা স্যার বলছি ওই যে মানে কি বলবো ওর যে এক্সাইটেবিলিটিটা অনেকক্ষণ ধরে মানে অনেকটা কম টাইম মানে মানে কি বলবো
There are two things. One is magnitude, and the other one is time.
মানে আস্তে আস্তে বাড়ছে বাট পিকটা একটু টাইম নিয়ে
Okay, got it. Let's hear from Devasmita.
স্যার আমি ওই প্রথম ওটাই বলতে চাইছিলাম যে ম্যাগনিটিউডটা কম হচ্ছে, তো ওই জন্য ওটা ন্যারো হয়ে যাচ্ছে।
All right. So always remember, magnitude should be, if you have to say magnitude is less. Suppose I want to say that Q magnitude is less. That means it should be like this much. If I say R magnitude is less, it should be this much. If you have to say S magnitude is less, then it has to be this much. Less.
স্যার ম্যাগনিটিউডটা তো সেমই থাকছে তাহলে।
হ্যাঁ, ডেফিনেটলি আই এম সেইং অনলি ন্যারো কিউআরএস।
যে মানে মানে ভেন্ট্রিকুলার সিস্টোলটা খুব তাড়াতাড়ি হচ্ছে বলে কি ন্যারো হচ্ছে?
এক্স্যাক্টলি, সো দ্যাট ইজ দ্য থিং।
ওটাই বলছিলাম লাইক প্ল্যাটো টাইপের ফর্মেশন।
হ্যাঁ, রাইট। সো ইয়েস, Obhirup and Shomil has given the correct answer actually. So Devasmita, have you understood this? Magnitude, if you have to say, magnitude will always reduce the amplitude, the height.
হ্যাঁ স্যার, বুঝতে পেরেছি। আমি ভাবছিলাম হয়তো মানে ম্যাগনিটিউডটা কম হচ্ছে জন্য জিনিসটার ওই উইথটা মানে ন্যারো হয়ে যাচ্ছে।
No. Magnitude. Remember, it was all about that galvanometer ka kanta. If galvanometer ka kanta goes this much, then height will come up like this. If galvanometer ka kanta goes only this much, then height will be less. But galvanometer ka kanta from here, and then it goes from here and then comes back over here. How much time it is taking, that will decide whether its width is wider or narrow. Think, Devasmita. Understood or not?
হ্যাঁ স্যার, বুঝতে পেরেছি।
বোঝা গেছে?
হ্যাঁ, আপনি ওই পেপার রোলটা আগের দিন বলেছিলেন না, ওটা আর কি
হ্যাঁ, ওইটাই তো কনসেপ্ট। that was the
এটা করছে, তাহলে তো ওটা কম হবে, সরু হয়ে যাচ্ছে, টাইমটা বেশি হচ্ছে, তাড়াতাড়ি হচ্ছে বলে।
হ্যাঁ, for this purpose only I had that discussion on ECG, so that these concepts become clear. This is the purpose only. Okay, so now everybody is clear, I guess. So let me remove this. Okay, so you see, if QRS complex is narrow, that means it is happening very rapidly. When time duration is short, when it is rapid. So that means if QRS complex is narrow, that means there is like AV node, it can also happen na, that SA node is also firing along with that AV node is also firing. Can happen. QRS will detect, or QRS will tell us about the electrical activity in atria or ventricle.
স্যার ওটা
Ventricle, na?
ventricle.
So, if QRS complex tells us the condition of ventricle, that means ventricle is depolarizing rapidly. So, how can ventricle depolarize rapidly? Because SA node though will take some time. It is only possible if SA node along with AV node is working. Somebody has to give more stimulus na, so that it can happen very quickly. Do you get it?
Yes, sir.
Normally AV node's job was what? To make the nodal delay 0.1 second. Remember?
হ্যাঁ স্যার
So if that this was the job of AV node, but and after that the QRS complex will start. But imagine that this during this time AV node also fires. That means now ventricle is not going to conduct the impulse of SA node. It will conduct the impulse generated by AV node. So definitely it will happen faster. It won't take so
স্যার
much
তাহলে
time.
তখন তো দুটোই থাকছে না, মানে
ওই জন্যই তো it will happen faster. দুটো থাকছে বলেই। বেশি ইম্পালস আসছে না, তো বেশি ইম্পালস বারবার আসছে। যখন বারবার একটা এসএ নোডের ইম্পালস গেল, আফটার দ্যাট এভি নোডের ইম্পালস যাচ্ছে, সো ব্যাক টু ব্যাক দেয়ার আর ইম্পালসেস কামিং আপ, ওই জন্য ইট উইল হ্যাপেন ফাস্টার। গট ইট? So you see, if there is narrow QRS complex, so there can be a AV node active condition, there can be a AV node passive condition. So I don't want you to go into detail right now because we will have detailed discussion on this. So I'm just classifying it. So there is a condition where it is AVRT, and there is a condition where there is AVNRT. So Oviru, can you tell me what do you mean by AVRT and what do you mean by AVNRT? Like only, let's say, the full form.
স্যার ওটা ছিল দাঁড়ান স্যার স্যার একবার নতুন খাতাটা একবার নিয়ে আসি আগের দিন একটা।
আচ্ছা, AVRT is atrioventricular reentrant tachycardia and AVNRT is atrioventricular nodal reentrant tachycardia. Actually today's lecture should be all on the reentrant. What do you mean by the word re-entry? We will have that discussion. So that is why I am saying that right now do not get bothered about it, just understand it. What is the full form of it? AVNRT is atrioventricular nodal reentrant tachycardia and AVRT is atrioventricular tachycardia. Next is the passive type, that is AV node is passive. QRS complex is narrow but AV node is passive. Now if it is passive, there can be two further conditions, whether it is happening regularly or whether it is happening irregularly. Now comes up QRS complex wide. What do you mean by wide QRS complex then? Meaning of wide QRS complex?
স্যার মানে টাইমটা বেশি লাগছে,
টাইমটা বেশি লাগছে। সো টাইম বেশি লাগবে কেন? So what can be the reason for time বেশি? So one thing is that maybe
ফায়ার করছে না,
হ্যাঁ, maybe the ventricular tachycardia originates below the bundle of His. That is why it is like taking lot of time. Frequency is high but they are taking time because it is a weak impulse na. If the origin of the tachycardia is below the bundle of His, so frequency of bundle of His and frequency of SA node will not be same na. So impulse generated by bundle of His will be weaker impulse than that of SA node. Correct or not?
yes sir.
So that is why it can be wide, and later on I will teach you that how they can be monomorphic and polymorphic. For the time being, just understand in this way. Morph means structure. So the structure wide QRS, but if you look at the ECG, all the QRSs will look similar, wide but same. And another one is wide but different designs are there. The QRS complex doesn't look same. So many shapes, many structures, so polymorphic. Single shape or single structure is monomorphic. Understood? And then there is another reason, that is supraventricular tachycardia with aberrant conduction. This I will tell you later on. So have you got what is written over here? I will go into details of all these things, but have you got what is at least written here in the classification part?
স্যার
হ্যাঁ।
ওয়াইডের সেকেন্ড টা কি লেখা আছে এটা একটু বলে দিন।
Supraventricular tachycardia with aberrant, ABERRANT, aberrant conduction, SVT with aberrant conduction.
ওকে, মানে ওটা
Huh. We will discuss that right now. Don't get bothered about it.
ওকে ওকে ওকে
Huh. So let us begin with tachycardia. That what is this? How tachycardia takes place? I was telling that tachycardia can occur by three ways. There can be a case of increased automaticity. There can be a case of triggered automaticity, and then there can be a case of re-entry or circus movement. So I was just telling this, that suppose, let's say, if we talk about one by one, increased automaticity. So how can increased automaticity take place? This is a graph of action potential. So both of you, except Oviru because he has attended it, so rest both of you, have you understood this action? Do you know this action potential? This is from intermediate classes. Do you know this action potential business? Or you have, I think you studied first year also.
হ্যাঁ ওই মানে ওই নার্ভে পড়েছিলাম তো।
কেন হার্ট ফিজিওলজি অ্যাকশন পোটেনশিয়াল?
স্যার দেখতে হবে একবার বইটা।
আচ্ছা, ওকে, তো আই জাস্ট হ্যাভ আ ব্রিফ রিক্যাপ অ্যাবাউট ইট। সো first, that orange line which is present, so this orange line is depicting or I don't know, it is like this orange line is depicting that there is resting membrane potential going on. The muscle membrane is at rest. Now what happens is, what is so special, what is the special thing about SA node? You know, special thing about any node is that they have something called as automaticity. Human heart is myogenic. Muscles have the capability to generate impulse. But how is it possible? So it is possible because in our body, the heart has got some this sodium ion channel which are leaky channels. They are always open. Okay, sodium ion channels are always open. And sodium trickles in. Have you seen that sodium ion channel left hand side?
হ্যাঁ স্যার।
So as sodium is trickling in, the cell is getting loaded with positive ions, cations. As the cell is loaded with the positively charged cations, the graph will increase because we will be moving towards zero potential. Usually it is what, minus 60, so it will keep moving towards positive integer, towards, it will become less negative, so upward it will go. Correct?
হ্যাঁ স্যার।
Now this is called as the threshold potential. This dashed line which I have made, this is the threshold. As threshold potential comes up, what happens? Voltage gated calcium ion channel will open, and calcium is more where, in ECF or in ICF. Always remember, calcium is more primarily in the ICF, in the ECF, in the extracellular fluid. So in the extracellular fluid, calcium is always more. So if in extracellular fluid calcium is more, then calcium will go out or calcium will come in. What do you think?
Come in.
Yes, so calcium will come in. So if calcium enters in, then again the cell is getting loaded with positively charged cation. So more, this entire thing will keep moving upward. How long? Till the calcium channel will close. Now this is called as depolarization. I hope this much basics you know. This is depolarization. Yes or no? Depolarization you know? So now afterward, potassium channel will open up. So potassium is more in the intracellular fluid or in the extracellular fluid? What do you think?
Intracellular fluid.
Yes, so potassium is more in the intracellular fluid. So the potassium, if influx will take place or efflux will take place?
Efflux.
Yes, potassium efflux will take place. So if potassium efflux takes place, then what will happen? The cell technically will be losing out the positively charged cations, and if the cell is losing out the positively charged cation, then the voltage will start declining, and if the voltage starts to decline, graph will also come downward. This is called as repolarization, and by the time it comes in, you will see that again sodium starts to trickle in. When sodium starts to trickle in, again the same thing will repeat itself. Do you understand this? Yes or no?
Yes, sir.
Okay. So now imagine that you give epinephrine, okay, for some reason. Okay, maybe you are walking down the street. Let's say Devashmita is walking down the street, and in front of him, Tom is cruising in front of her. Okay, in front of her, Tom is cruising. So naturally, Devashmita's heartbeat will increase or decrease or remain same. What do you think? Let's see how much faith you have on her. Heart rate will decrease.
স্যার ওটা ওকেই জিজ্ঞাসা করুন।
Okay. The question goes to Devasmita directly. So suppose you are walking, and suppose Mr. Shah Rukh Khan comes up in front of you. So heart rate should increase, decrease or remain same?
ইনক্রিজই হবে স্যার।
Correct. So see, we all had faith on you. So heart rate will increase. But why? Because at that time, Devasmita's personal adrenal gland, primarily adrenal medulla, will start secreting a large number of adrenaline, or the sympathetic nerves will start releasing a large number of epinephrine. Now, in your cardiac muscle, there are present large number of epinephrine receptors. So those epinephrine receptors will bind with the epinephrine, and finally there will be, I hope you have studied in the cell signaling, that there are some second messengers present, cyclic AMP, CAMP, cyclic adenosine monophosphate. Heard of it, second messenger? So finally, so they will phosphorylate and they will open up some calcium ion channel, leading to more influx of calcium. So you see, I have shown with green colored dotted lines that if there is more calcium influx, do you realize that now the action potential will be more frequent? More calcium will enter in, so action potential can generate from here also. It can be more frequent. Everybody understanding this? Frequency, how is it increasing? So if you notice in the ECG, if this happens, let's say from the atria, then look over here. Can I have this kind of situation that there are two P waves? Bol, yes or no?
So, two P waves.
Suppose this is your beautiful heart, and let us say this is the SA node. The SA node fired, correct? Again fired because of epinephrine, increased automaticity. So for this there will be a P wave. For this, don't you think there will be another P wave? When the second P wave is coming up so early, if the second P wave is coming up so early, do you think the AV node is fired by that time?
No.
না, তো তাহলে both the P waves should be before QRS or should be after QRS?
বিফোরই হবে।
Everybody agrees with this?
স্যার আমি একটু বাথরুম গেছিলাম।
আচ্ছা, rest everybody agrees? তুই তো ছিলি আগে।
হ্যাঁ স্যার,
Okay.
মানে
So
আমি তো এগ্রি করছি।
হ্যাঁ, তো see this is the reason for the two P waves. So two P waves will precede a QRS, or there can be a situation that suppose P wave is firing very frequently. So do you think that after T wave the duration that usually remains before the next P wave, that duration will persist, or this duration will shorten, or this duration will elongate? Shorten হয়ে যাবে. Very good. So you see these are the changes that we can see over here. Tell me understood or not?
Yes sir.
Okay, so this is what I was telling about increased automaticity. So this is the story of increased automaticity. So here I was telling a few facts about the membrane potential because he forgot it, but anyway this is very basic physiology. Acha, next thing we talk about the triggered automaticity. So 3 points were there. One was your increased automaticity, one is triggered automaticity and re-entry. So let's talk about what is triggered automaticity. So this graph, are you acquainted with this kind of a graph? That first there is a resting potential if you look at the right hand side. So then what happens is sodium enters, and when sodium enters, so there is a sodium dependent depolarization. So when sodium dependent depolarization will take place, after that there will be potassium channel will open. So potassium efflux will occur. When potassium efflux will occur, it will keep going downward like this. So this is where the potassium efflux is going to take place. During this point of time the calcium channel will open up. When calcium channel will open up, then what will happen? Then calcium influx will take place. So you see at this point of time there is both cation loss and cation gain going on. So what do you think? The graph should go down or graph should go up, or the graph should remain stable? Constant. Stable. So you see this is where the graph remains stable. So this is that this is called as a plateau phase. This is a plateau phase, and then a time will come up when this calcium channel will close, because like we discussed earlier also, calcium channel will close spontaneously after few seconds. So that time potassium channel is still open, so now there will be more cationic loss going on, so graph will come downward. So are you acquainted with this kind of graph? It will reach the resting potential afterwards. So depolarization which is happening, that is phase 0. We call it as phase 0. So all of these are phase 0. Now then when potassium efflux is going on, then that is called as phase 1. Okay, anywhere you see you are going to call it as phase 1. And after that when the plateau phase is coming up, that is called as a phase 2. Okay, so this will be called as phase 2. And then the part where next part will be called as phase 3. So this is the phase 3. And then finally when again resting membrane comes up, resting potential area is called as phase 4. So this is the phase 4. So usually in cardiology sometimes we talk in terms of phases, that phase 1 is affected, phase 0 is affected, phase 2 is affected. So you have to correlate with this. Understood or not this part?
Yes sir.
Okay, now when it comes up to triggered automaticity, there are two fundamental things that all of you should remember. So one is called as this is the AD, EAD, and there is DAD. Now what do you mean by AD? AD means after depolarization. So depolarization is taking place, now something is happening after it. So if we talk about AD, so it can happen a little bit early or it can happen a little bit late. So if I talk about after depolarization, so it can happen early after depolarization or it can happen late after depolarization. By looking at the graph, the diagram, can you understand how one after depolarization is happening early and how another after depolarization is happening delayed? Yes or no? Okay, so I'll now explain it that how it is happening, don't worry. So imagine if plateau phase gets prolonged. Okay, due to it can, like, how can plateau phase gets prolonged? Plateau phase can get prolonged because of two reasons. Either there is calcium influx prolongation, calcium is entering for long duration, or there can be potassium efflux prolongation. Okay, in both these cases there will be plateau phase prolongation. So what do we understand? If you look at the lower left picture, if you remember about the sodium ion channel, when sodium influx was going on, at that time sodium channel was open or closed? The voltage gated sodium channel? Voltage gated sodium channel, both activation gate as well as inactivation gate was
open though.
open, of course. Both activation gate as well as inactivation gate, they were open. But at the top of it, what happened? The inactivation gate will close eventually. That's what we have learnt earlier, that the inactivation gate is going to get closed over here during this time. So this gate is getting closed. So at this point of time, activation gate is still open. So that is nothing to mention over here. That is normal. Okay. Now when it comes up to look at phase 2, that time also sodium channel should be closed like in the diagram I have mentioned. When phase 3 comes up, then also sodium channel should remain closed. But after that, when phase 4 will come up, at that time sodium channel should open now. Now remember, so that means what I am saying, when plateau phase is getting prolonged, sodium ion channel configuration changes to inactive, because normally sodium ion channel should come back to rest after a while. Not getting?
Sorry.
Okay. So when this is happening, sodium channel is inactive. Sodium channel is active. Now sodium channel is inactive. Correct? Sodium channel is still inactive. Then sodium channel still inactive. And now again sodium channel should become active. Now imagine this, that when sodium channel is back to normal, at that time imagine the voltage of the cell, because of any reason, which I'll tell you the reason, but because of any reason, suppose the voltage of the cell is still above the threshold potential, then will sodium channel remain closed or it should try to open up if there is prolongation? Because normally in abnormal situation, what is happening? Let's see. In abnormal situation, this has happened fine, this has happened fine, that this has got prolonged. So when it has got prolonged, this prolongation is because of calcium and potassium. In this, sodium ka koi dosh nahi, sodium has got nothing to do with it. So sodium to will come back to rest na. This entire prolongation is happening because of calcium and potassium. So what should sodium do here? Sodium is coming back to rest. Correct ki na? But when sodium is coming back to rest, sodium is seeing that the potential of the cell is high or low. What is the potential right now? It is this kind of high potential. Na? Look at the picture. Potential is high. So in this high potential, what is the nature of sodium channel? Voltage gated sodium channel. So sodium channel gate should remain open or it should remain closed?
Close it হওয়ার কথা.
Suppose this is, say, plus 10 or say 0 millivolt. So at 0 millivolt, sodium channel remains closed or sodium channel remains open?
জিরো তো আবার ওপেন হবে।
হবে তো? তো that is the point. So at this point of time, the sodium channel, can it remain closed? So here sodium channel got closed. Here sodium channel was open. Here sodium channel already got closed, and sodium channel should remain closed at this point of time. But because of this situation, can sodium channel remain closed?
নো।
No, na. So definitely that is the point. That is the point of the entire discussion. That during this point of time there will be sodium channel opening, and again there will be a depolarization coming up. This thing. Look whether you understood or not.
ইয়েস।
This is called as early after depolarization. Could I explain it to all of you?
হ্যাঁ স্যার।
Acha. So that means if I can open the potassium channel faster and let potassium go out faster, can I correct this situation?
ইয়েস।
Yes, that means if I have got any drug which can open the potassium ion channel, so can I correct this situation? So do you know any drug which opens a potassium ion channel?
ভুলে গেছি।
Nicorandil. There is a drug which is called as Nicorandil. Okay, and there are other drugs also like chromacalin or pinacidil. But if you talk about potassium channel openers, then we can use these kind of drugs. Okay. Now another thing, if the cell possesses too less potassium, that potassium cannot go out, then can you treat that condition? Cell's intracellular fluid does not even have potassium. So can you treat this condition with calcium channel opening drugs?
হ্যাঁ।
Okay, how?
ক্যালসিয়াম চ্যানেলটা বন্ধ করে দিলেই তো আর আসতে পারবে না, মানে ইনফ্লাক্সটা বন্ধ হয়ে যাবে।
Okay, but calcium channelটা আসতে পারবে না, but potassiumটাও তো বের হচ্ছে না, because cell does not even have potassium. তো membrane potentialটা নামবে কি করে? How can the membrane potential come down? You are stopping calcium influx. Okay, fine. That means that plateau phase will shorten, but how will the potassium level, how will the graph come down if you cannot release the potassium? Phase 3, look at phase 3. Phase 3 is because of what? Potassium or calcium? Phase 3 is taking, it's all written on the screen. I just now told it. Phase 3 is occurring because of calcium or it is occurring because of potassium? Potassium. So if you want the graph to come down, so that means you are targeting phase 2 or you are targeting phase 3?
Phase 3.
So how can you talk about calcium? You have to deal with potassium channel openers. Understood? So in potassium channel openers, there are something called as, there is a group of chemicals called as benzopyran. Now benzopyrans will include those things, cyanoguanides, okay, chromacalin, nicorandil. So these kind of drugs come under that. So by doing that, we can do this potassium channel opening thing. But if you do not have potassium, cell does not have potassium. If cell does not have potassium, what is that condition called? That condition is called as
hypokalemia.
Yes, very good. Hypokalemia, correct. So if there is hypokalemia, will the KCA, will the potassium channel openers help? Nah. That means you treat hypokalemia first. If you treat hypokalemia, then automatically the problem may be getting solved. Okay. Understood? Think and tell.
স্যার হাই এই জায়গাটা আরেকবার বলুন না, হাই
Suppose this cell does not have calcium, then can potassium channel opening drugs treat early after depolarization?
না, মানে পটাশিয়াম যদি নাই থাকে তাহলে কি করে?
Exactly. So jodi if I can treat hypokalemia, then potassium efflux will take place, maybe the disease will get corrected. That is what I am saying. So okay, so you have to treat hypokalemia if there is hypokalemia in the patient. Otherwise it will be difficult to treat early after depolarization. Okay, and remember, if there is early after depolarization, do you realize one more thing, that is there will be what can I say, there will be the QRS complex will take place. Okay, but between QRS and T wave there will be a long delay. So I can say that there is QT interval prolongation will take place. Now, if you remember last year we discussed in pharmacological lectures that class 1A and class 3 antiarrhythmic drugs, they are antiarrhythmic but they have like feature of QT prolongation. Class 1A and class 3 antiarrhythmic drugs have got a feature that they can prolong the QT interval. In this case already QT interval is prolonged. In this case already QT interval is prolonged. So can we use class 1A and class 3 drugs?
হ্যাঁ স্যার।
So class 1A and class 3 drugs, they perform QT prolongation. Already your QT is interval is increased. You
No.
use the, what are you saying?
I don't know.
Okay, are you getting it?
Yeah.
So it was very simple question. How can you give QT prolonging drug to a condition where it is already there is QT prolongation?
Prolongation.
And I think you should better know this, because class 1, like if I talk about class 1 drug or class 1A drug, that is primarily quinidine. If you remember, there is a thing called as quinidine drug. So class 1A, the like if you remember the names, do you remember the names? No. Procainamide, quinidine. In our local anesthesia, we use lidocaine. Lidocaine is class 1B, but anyway, this is class 1A. We are not going for class 1B, but this is class 1A. Quinidine, procainamide, these are class 1A drugs. Lidocaine is a class 1B drug. Then flecainide or propafenone, these are all what? I forgot. Okay, anyway, leave it. So anyway, for the timing, just remember class 1A drug and class 3. Do you know what are like class 3? Have you heard of something called as amiodarone, sotalol?
হ্যাঁ স্যার।
So these are all class 3 antiarrhythmic drugs. So these you should not give if you think that there is early after depolarization. Understood? Yes or no?
Yes sir.
Okay. If you okay, now we talk about the delayed after depolarization. So delayed after depolarization. So why do you think delayed after depolarization will take place? So I think okay, we haven't discussed about delayed after depolarization. Okay, I don't think so. Okay, anyway, So suppose we talk about, achha, we have discussed. Okay. So suppose we talk about the cardiomyocyte. Look at the upper left picture. So there is one more thing that all of you should be noticing. These cells have something called as a sodium calcium exchanger. Okay. So there is something called as a sodium calcium exchanger, and also along with that there is present that sodium potassium ATPase pump. So there is a pump which throws out, you remember that there is a pump which throws out 3 sodium ion and 2 potassium ion utilizing ATP.
Yes, sir.
Yes, and also remember that there is a sodium calcium exchanger. So what happens is when sodium enters in, some of the sodium is going to go out. Oh, it's written ulta actually, let me correct it. So when sodium influx takes place, okay, when sodium influx will take place, so some of the sodium, is going to go out. So sodium goes out. ठीक ना? And how will it go out? So this pump which is working here, this pump needs calcium. So if calcium can enter in, okay, from outside, only then this pump will work. If calcium can enter in, only then this pump will work, and this is called as a sodium calcium exchanger. Okay, now normal this myocardium, if we talk about, its potential is almost minus 90 millivolt. Okay, this is minus 90 millivolt, and threshold potential comes up at around minus 70 millivolt. Now as cation leaks in, it raises the potential to the threshold, and this opens the voltage gated sodium channel. Sodium channel will close, potassium will open, then potassium efflux takes place at 0 millivolt, then calcium channel opens, then calcium influx occurs, that is plateau I am talking about, along with potassium efflux, that is like once the plateau is over, then calcium will close. Actually when the calcium will close, plateau will get over, and potassium efflux will bring about repolarization. And then like electrical membrane, that resting membrane potential is achieved, sodium is pumped out by the sodium calcium exchanger and sodium potassium ATPase. Got it? The thing, now imagine there is a condition. Now I am going to tell you about another condition. Last time we discussed about hypokalemia. Now I am telling you, what if there is hypercalcemia? Meaning inside the cell calcium level is high or low?
Sir, high.
High. So already inside the cell calcium level is high. Or maybe suppose that you remember that epinephrine wala funda. Due to that epinephrine, this lower picture, due to that epinephrine, maybe you know there is an adrenergic rush. Okay, like that SRK. There is adrenergic rush. Cyclic AMP path opens up calcium ion channels. Okay, so if that happens, so one situation is hypercalcemia. Second situation is adrenaline rush leading to calcium increase. In either way, any condition, calcium level inside the cell if goes high. And even remember, that can also happen due to digitalis toxicity. Why? Because digoxin, if you remember last year pharmacology lecture, digoxin blocks sodium potassium ATPase. So if sodium potassium digoxin, you remember digoxin blocks sodium potassium ATPase here. Digoxin works. If digoxin works over here at the sodium potassium ATPase, it blocks it, then cardiomyocyte will try to go back to the resting state via sodium calcium exchanger. Because sodium potassium ATPase is not working. If sodium potassium ATPase is not working, then who will throw calcium out? How will the cell achieve the resting potential? You tell me. What is the opinion, what is the option cell has to achieve the resting membrane potential? Cell will try to come back to normal condition, na?
হ্যাঁ স্যার মানে
But digoxin toxicity has occurred, digitalis toxicity has occurred, and sodium potassium ATPase is band, stopped. So what other option the cell has? Do you know? अरे sodium calcium exchanger is there ना?
হ্যাঁ হ্যাঁ হ্যাঁ
There is sodium calcium exchanger is also present here. Keep your eyes open. Here there is a sodium calcium exchanger. So cell will get dependent on sodium calcium exchanger. If cell is trying to throw out sodium through sodium calcium exchanger instead of sodium potassium ATPase, then calcium is entering more or calcium is entering less. If sodium calcium exchanger pump is very much active, so cell will gain zero calcium, more calcium, less calcium.
মোর ক্যালসিয়াম
More calcium. So you see these are conditions in which there is the cell is getting loaded with calcium. So one situation is hypercalcemia, one situation is digitalis toxicity, and one situation is if there is a adrenergic rush. Understood or not?
ইয়েস স্যার
Oh, finally understood. Okay. So, during this time, even during repolarization, where only potassium efflux takes place, though the cell reaches RMP, but since the cell is highly loaded with calcium, don't you think that again action potential will be triggered? So this triggering will take place just after phase 3. That is why we call it as delayed after potential, after depolarization, delayed after depolarization, DAD. Understood or not?
হ্যাঁ স্যার
So basically, this is the story of triggered automaticity. After this, we are supposed to discuss re-entry. Do you have energy for re-entry today?
ইয়েস স্যার
Sure?
হ্যাঁ
Okay, rest of the people?
Yes, sir.
Yeah?
Yes, sir.
Okay.
Almost.
So let's talk about re-entry. Chalo, let's talk a little bit on re-entry. Let's see whether you can take it or not. So this is the third part of tachycardia. Okay, and actually this is the final part of tachycardia. So that is re-entry. Re-entry is also called as circus movement. Something circus is going on here. So what happens here? So suppose we say this is a myocardium. Let's suppose this is a myocardium. So if this is a myocardium, say in the heart tissue, there is an area which has gone dead. Okay, so there is a area which has died. Some area is infarct. In pathology of studied, I guess. So this area, this is dead. It has died. So in the heart muscle, if this area is dead, and suppose the impulse action potential is traveling from here, can the action potential cross this dead area?
না তো
Nah, right? So what happens is that it is going to bifurcate. It will try to go from the right side or from the left side. It will go from either side, maybe, or both the sides. So the current will move with the same velocity on either side at the same time. Now think of this situation. So try to understand. Okay, I'll show you a very simple concept. So imagine I just repeat the heart tissues. So these are the heart conditions. So my point is this, that after the situation, this area was damaged. So let me damage the area. This is the dead area. So try to understand this. Just one headache concept is here, but if you understand it, it's very simple. Rest is very simple. So imagine about the, say, side A and side B. So do you see that the impulse which was traveling, so with the same velocity it is traveling on side A as well as side B. So now let us focus on side A, only A. So you tell me something. If this impulse is going like this, like this, like this impulse is supposed to go like this again. It can go na, because this area. But try to look at the first picture. Just a moment back, actually it was traveling at the same speed. So just a moment back, through this side already impulse has traveled. Through this side already impulse has traveled. The B wala impulse has traveled. So don't you think that this is hyperpolarized, which is called as refractory period? Don't you think that this area is refractory? Understood, yes or no, everyone?
Yes, sir.
Okay. Now tell me, if I do it reverse, does the story change or does the story remain same? Like, suppose this area is damaged, and this time I don't want to talk about A, I want to talk about B side. So I'm talking about B side. So if the impulse is coming like this and then it is going like that, is it supposed to go in this direction? But don't you think that this area is refractory, because just a moment back through this area impulse traveled? So that means, can it go to the opposite direction, the impulse, any impulse A or B, can it go to the opposite direction?
I think no.
Yes, no. Because what is the reason? Because the opposite sides are refractory. That means the impulse has to go like this and then they will go like this.
Like this.
Agreed? Now, the twist is this, that sometimes the pathways are electrophysiologically dissimilar. So one path allows the current to move fast and another path will allow the current to move slower. They are dissimilar. The paths are not similar, because you cannot expect, no? It's after all human body. So everything cannot be like all even and equal. So sometimes they are dissimilar part. So one path allows current to move fast and another part allows it to move slow. Now, it is seen that the limb which shows faster conduction, it shows slow refractory period. Okay, and the limb which shows slower conduction is going to have faster refractory period. Can you remember this part? Conduction fast, fast conduction, slow refractory. And if it is slow refractory, then there will be fast conduction. Sorry, if there is slow conduction, then there will be fast refractory. If there is slow conduction, then there will be fast refractory. This you have to remember. This is the funda that you have to remember. Everybody agrees?
Yes, sir.
So, when something is moving forward, we call it as, like, these are some terminologies which I am explaining. When something is moving forward, we call it as antigrade. antegrade, because I'm going to use these terms. And I don't think they're very difficult. If something is moving backward, that is called as retrograde. Okay, so fast pathway impulse proceeds antegrade or anterograde. You can call it anterograde. Now, if there is a fast pathway, it is moving anterograde. Can it move retrograde?
No.
No, because why? It cannot move retrograde?
We refract.
Correct, very good. It is refractory. Because if it is fast pathway, it cannot move retrograde because it is refractory. But slow path, if there is a slow path recovers from refractory faster, because we just learned this, that if there is a slow conduction, then refractory period is like refraction takes place early. So the next impulse can enter the slow path first. Not getting?
No.
Okay, don't worry. Let us suppose this purple color area is slow, and let us suppose this wala area is fast. Now let us say that the impulse is traveling. So let's talk about again A and B. Okay, let's do this. Achha, now we have got colors also. So let us suppose the fast side. When fast one is moving, so the fast one goes like this, and can it go in this direction?
No.
Okay, because that side is supposed to be refractory. My point is not that. My point is this, that this fast will go like this, in this direction. And can the fast impulse, can it go backward? It cannot go backward because it is also refractory, so it cannot go backward. Now, think of the slow side. Slow side means the other side. So in the slow side, impulse is traveling like this, and it is going like that. It is going like that. And then it will travel like this. But do you realize that on this side, refractory phase will occur early, like the tissue will recover early, or the tissue will recover late? Early. So if that is my point, if the tissue is recovering early, can't I say this, that some impulse can move in this direction because it is recovering early? This is so what is happening? There is a re-entry going on. Try to understand. I am repeating once again. Fast pathway impulse is proceeding anterograde, and it cannot move retrograde because it is refractory. But the slow path, it recovers from the refractory early. Hence, the next impulse can re-enter the slow path first, and the same impulse might enter the fast path also. Why it is entering the slow path early? Because it has got recovered early. Why it is entering the fast path early? Because it is fast, it has already traveled. So what we see, so do you realize that as this impulse is traveling again and again and again via slow pathway, by now the fast pathway will, it has somewhat recovered also. Slowly and gradually fast pathway will also recover. Slow refractory, but ultimately there will be refractory. So at this moment, this impulse which comes through the slow pathway enters into the fast pathway in a retrograde direction. Understood or not understood?
Yes.
See, this is another different situation I am talking about. So this was the fast side, and there was the slow side. My point is this, if this area has recovered early, if this area has recovered faster, that means the impulse which is present, next impulse that will be coming up, let's say next impulse which is coming up, this is the next impulse. So you tell me, fast side, slow refractory, slow side, fast refractory. So you tell, this was impulse 1, this was impulse 1, and let's say this one is impulse 2. So impulse 2, it should move on the blue side, I mean purple side, or it should move on the red side?
Sir, red side is slow or fast?
It's written, no? Red side is fast conduction and slow refractory.
Blue is slow, okay.
Correct. Cano, why not fast?
Because ওখানে তো স্যার মানে এখানে তো টিস্যুটা রিকভার হয়ে গেছে।
Exactly, very good. So on the slower side, the tissue has already recovered, because slow conduction means fast refractory. So this has recovered. So we see that again and again more impulses will travel through the slow side, because it is recovering early. Okay, so at this moment, this impulse which comes through the slow side eventually can enter the fast side also, now, because when the fast side, eventually, not every time, but after certain time, when the fast side has recovered, this can also go into this direction. When the fast side has recovered. So what do we see? Around this dead tissue, in either case, around this dead tissue, do you see that there is a goal, circle, again and again and again and again, there is a movement going on of the impulse? This is re-entry. When it is revolving and revolving in a cyclical manner, there is again and again and again entry is going on. Entry of what? Entry of impulse is going on again and again and again. This is called as re-entry, or this is called as circus movement. Understood or not understood? Tell me.
ইয়েস স্যার, তার মানে যেটা হচ্ছে সেটা হচ্ছে যে সবসময় যেটা আপনার স্লো যেখানে রিফ্লেকশনটা হবে, মানে যেখানে টিস্যুটা তাড়াতাড়ি রিকভারি হবে, ওই সার্কেলটা সেই দিক থেকে শুরু হবে, মানে স্লো থেকে ফাস্টের দিকে যাবে।
স্লো থেকে ফাস্টের দিকে যাবে, ইয়েস। Got it? So these are the three prime causes that we discussed about the tachycardia. So we have now understood what is our increased automaticity, what is triggered automaticity, and what is re-entry. So I won't torture much. So if you have understood the reasons, then we will talk about the types of tachycardia. That means next topic of our discussion should be that what is supraventricular tachycardia, what is sinus tachycardia, why it happens, what are ectopic beats, what are the reasons for ectopic beats, what is flutter, how flutter occurs, what are the types of flutters, what is a atrial fibrillation, okay, then junctional arrhythmia, junctional tachycardia. We will go into details of all these things. What are supraventricular tachycardia, what is now I hope now you will have a developed idea what is AV nodal re-entrant tachycardia. You remember we discussed about AV NRT and AV RT. So now I hope you will develop a hunch about what I might be talking about when I say re-entrant wala point. So this is that thing about re-entrant. So we have to discuss all this. I don't think you have like energy for all those things today. So let us stop over here today. In the next class we will be continuing with the types of tachycardia. Okay.
Yes, sir.
Chalo. Thank you everyone. Good night.
Good night, sir.
Good night.